Your doctor spends more time typing about you than actually looking at you. I want you to sit with that for a second. Not because your doctor doesn't care. Your doctor almost certainly got into medicine because they care deeply. But right now, in 2026, the average physician spends more than half of every working day inside the electronic health record. More than half. That is not a personality flaw. That is not a workflow issue that a better training module is going to fix. That is an operating system bug. And today I'm going to tell you exactly what that means and what comes next. Let me introduce myself. I'm Dr. Trevor Turner. I'm a physician, board certified in physical medicine and rehabilitation with a regenerative medicine fellowship. I'm also the co-founder of Pravida Health in Atlanta. And I want to start this series by saying something that most medical content on the internet will not say. Medicine has an infrastructure problem, and AI is not going to fix it by being smarter. It's going to fix it by being better organized. Here is the daily reality in most clinical practices. A patient walks in with knee pain. The physician has maybe 15 minutes. In that 15 minutes, they have to take a focused history, do a physical exam, interpret any relevant prior imaging, document the encounter in the EHR, enter orders, write a referral if needed, generate a patient instruction sheet, queue up the billing codes, and respond to messages. Then they do it again and again, 15 times a day, sometimes 20. And then, after the last patient leaves, they spend another 2 or 3 hours finishing the documentation they could not complete in real time. We have a word for that, pajama time. It is a real phrase in clinical medicine. It refers to the charting physicians do at home after hours in whatever they're wearing when they finally sit down to catch up. Studies have put the number at 1 to 2 hours of after-hours documentation for every 8 hours of patient care. Some specialties are worse, primary care is worse, complex medicine is worse. Now, I want to be precise here. The number I keep coming back to is from a 2025 Oxford paper, the MedicalOS paper by Jared Zhu and Junde Wu, which references the data point that physicians now spend more than half their working hours in EHRs, more than half. This is not a new finding. Researchers have been documenting this creep for over a decade. But what is new is the clarity with which the research community is now naming it. This is not a physician problem. It is an operating system problem. Let me explain what I mean by that. EHRs, electronic health records, were built to digitize paper. Before EHRs, you had paper charts. The EHR replaced the paper chart with a digital version of the paper chart. What EHRs did not do, and what they were never really designed to do, is automate the work around the chart. They digitized documentation. They did not automate clinical processes. That distinction is everything. Digitization means you have data in a computer. Automation means the computer does something useful with it. The gap between those two is where the burnout lives. The burnout data is staggering and I will not dwell on it, but I want you to understand the magnitude. Physician burnout rates have consistently run at 40 to 50% in large surveys over the past several years. Medscape's annual reports have documented this for a decade. The American Medical Association has called it a public health crisis. The reasons physicians cite consistently year after year are not inadequate pay, not difficult patients, not complex cases. The number one and number two reasons are always bureaucratic tasks and spending too many hours at work, documentation, administrative load, EHR work. And here's the thing I find almost darkly ironic about this moment in medicine. We are the most data-rich healthcare system in human history. We have digitized clinical records at extraordinary scale. We have imaging and PACS systems, labs and LIS systems, notes and EHRs, claims and billing systems. All of it exists. All of it is technically accessible. And yet a physician sitting in front of a patient in 2026 still has to click through 7 nested menus to find last year's MRI report. Still has to manually copy a medication list from one system into a referral letter. Still has to remember to send a follow-up order because the EHR does not know enough about the care plan to prompt one. The data is there. The intelligence to use it is not yet. This is what I mean when I say it is an operating system problem. In computing, an operating system sits between the raw hardware and the applications you want to run. It manages resources, it routes commands, it provides a common interface so you do not have to program to the metal every time you want to open a file. Medicine has the hardware, the EHRs, the imaging systems, the labs. Medicine has the applications, the clinical guidelines, the protocols, the physician's trained judgment. What medicine does not have is the operating system layer in between, the layer that translates clinical intent into coordinated machine action. The MedicalOS concept, and this is the idea I want to introduce in this first episode as a frame for the entire series, is that layer can now be built. It could not have been built 5 years ago because the underlying AI models were not good enough to understand natural clinical language and reason about it reliably. But in 2025 and 2026, the research has matured to the point where we can describe in technical detail what that layer looks like. And that is what this series is about. I want to ground this in something real for a moment because I think the danger with any content about AI in medicine is that it floats up into abstraction and never comes back down. So let me tell you what my day actually looks like and what the operating system problem looks like from inside a regenerative medicine practice. Pravida Health is not a primary care practice. We are a specialty practice. We do PRP, platelet-rich plasma injections. We do BMAC, bone marrow aspirate concentrate. We work with patients who have musculoskeletal injuries, degenerative joint disease, chronic pain conditions. Our patients often come to us after years of navigating multiple specialties. Orthopedics, physical therapy, pain management, sometimes rheumatology. They carry imaging reports from 3 different health systems. They have lab work from their primary care doctor. They have tried 2 or 3 prior treatments. Their case history is longitudinal and complex. When I see one of those patients for the first time, I am synthesizing information from 4 or 5 different sources, building a clinical picture and designing a treatment protocol that may span months. The EHR cannot help me synthesize that. It can store the documents. It cannot reason about them. So I do the synthesis manually, in my head, at the pace of a clinical encounter that is supposed to last 30 minutes. That is not a criticism of EHRs per se. They were not designed for that. They were designed to document what happened, not to reason about what should happen next. But here is where the operating system frame becomes genuinely exciting. Agentic AI systems. Systems that can reason, retrieve relevant information, and take sequential actions are for the first time designed for exactly that kind of synthesis. And I want to be clear about what I mean by agentic. I do not mean a chatbot that answers questions. I mean a system that can receive a clinical intent, help me work up this 52-year-old with bilateral knee pain, retrieve relevant history, cross-reference clinical guidelines, generate a structured exam request, produce a draft assessment, and flag gaps in the workup. All from one instruction. That is the REACT architecture. Reason, then act, that sits at the core of the MedicalOS design. Now, is that fully deployed in any US private practice today? Not completely, but the architecture exists. The papers describing it have been peer-reviewed and published. The underlying models are good enough to execute it. And several of the world's leading academic medical centers, Cedars-Sinai called Agentic AI the next trend in digital medicine in April of 2025, are actively building toward it. This series is about understanding that architecture well enough that, as clinicians and as patients, we are not surprised by it when it arrives. We are ready for it. We can advocate for the implementations that make sense and push back on the ones that do not. Let me be concrete about what an agentic operating system would change in a practice like ours, because I think the practical framing is where this series will be most useful. Right now, when a new patient comes to Pravida for a regenerative medicine consultation, there is a sequence of tasks that happens around that visit. The patient fills out intake paperwork, we collect prior records, a medical assistant enters a structured history, I review imaging, I document the encounter, I generate a treatment plan, a coordinator handles scheduling and pre-authorization, billing codes get entered, a follow-up protocol gets initiated, patient education materials get sent. That sequence involves, conservatively, 7 to 10 distinct administrative actions. In most practices, most of those are done by skilled human staff, who are doing work that is, frankly, below their cognitive ceiling and expensive to maintain. An agentic operating system would not eliminate those steps, it would orchestrate them. The agent would receive the clinical signal. New patient consult, knee prior imaging available, and it would retrieve the imaging report, extract the relevant findings. Structure the intake history into a usable format, prepare a differential framework, draft the note template, queue education materials, and initiate the follow-up protocol. My job, the physician job, is to review, decide, and maintain the human relationship. The agent handles the coordination. The documentation alone is transformative. The MedicalOS paper describes a workflow where a natural language instruction generates a structured clinical report, including history, exam findings, differential, plan, and medication recommendations. Validated across 214 patient cases in 22 specialties. That is not a demo, that is a benchmark study. For a practice like Pravida, that means a visit note that used to take 12 to 15 minutes to dictate and clean up could be generated in real time, reviewed in 2 minutes, and signed. Multiply that across 20 patients a day, and you have reclaimed somewhere between 3 and 4 hours of physician time daily. That is time I can spend with patients, or developing new clinical protocols, or doing exactly what I'm doing right now, creating educational content that grows the practice. Here is where I am going to push back on my own enthusiasm, because I think intellectual honesty in this space is essential. Simulation-based training has a well-documented limitation in medical education: transfer. Skills learned in simulation do not always transfer cleanly to the real clinical environment. Mannequin-based resuscitation training improves CPR technique. It does not fully prepare residents for the emotional reality of a resuscitation on a patient with a family in the hallway. The simulation optimizes for the measurable thing, the technique, the algorithm, and cannot fully replicate the unmeasurable thing. For AI agents, the analogous limitation is this: the synthetic patients in Agent Hospital are generated by language models. They behave the way a language model thinks a patient would behave, given a disease profile and a role description. Real patients behave in ways that are shaped by fear, language barriers, health literacy, cultural context, and idiosyncratic personal history. The gap between a clean synthetic patient and a real human being is real, and we should not paper over it. The 93% MedQA benchmark is meaningful evidence of clinical reasoning capability. It is not evidence that the agent can handle why. The patient who reports chest pain but actually has a panic disorder and a physician father who told her last year that she was fine. Those cases are where medicine lives, and simulation so far has not cracked them. I raise this not to dismiss the Tsinghua work, which I think is genuinely groundbreaking, but to frame the question we will dig into in episode 3. Can an AI actually take a clinical history? Because the answer is more complicated than the MedQA number suggests. Now let's look at the scientific contribution of Agent Hospital. Agent Hospital is, I believe, a genuinely important scientific contribution, not because it proves AI doctors are ready to replace physicians, but because it proves that simulation-based training for AI clinical agents is real, scalable, and capable of producing measurable clinical performance. That is new. That changes what is possible in medical education, in AI development, and eventually in the deployment of clinical tools. The Tsinghua AIR group built a hospital that does not exist. They trained doctors who have never touched a real patient on 500,000 synthetic cases. And what those doctors know, as measured by a hard clinical benchmark, rivals what a human physician knows at the board exam level. That is the AlphaGo Zero moment for medicine. But there is a gap between passing the boards and taking a great history. Next week, I will show you a benchmark that exposes that gap with precision. The AI hospital paper asks a question no prior benchmark had the nerve to ask. Not, can AI answer medical questions, but can AI actually talk to a patient? The answer will change how you think about every AI in medicine claim. I'm Dr. Trevor Turner. This is the Medical Operating System. See you next time. Here is where I am going to push back on my own enthusiasm, because I think intellectual honesty in this space is essential. Simulation-based training has a well-documented limitation in medical education: transfer. Skills learned in simulation do not always transfer cleanly to the real clinical environment. Mannequin-based resuscitation training improves CPR technique. It does not fully prepare residents for the emotional reality of a resuscitation on a patient with a family in the hallway. The simulation optimizes for the measurable thing, the technique, the algorithm, and cannot fully replicate the unmeasurable thing. For AI agents, the analogous limitation is this: the synthetic patients in Agent Hospital are generated by language models. They behave the way a language model thinks a patient would behave, given a disease profile and a role description. Real patients behave in ways that are shaped by fear, language barriers, health literacy, cultural context, and idiosyncratic personal history. The gap between a clean synthetic patient and a real human being is real, and we should not paper over it. The 93% MedQA benchmark is meaningful evidence of clinical reasoning capability. It is not evidence that the agent can handle The patient who reports chest pain but actually has a panic disorder and a physician father who told her last year that she was fine. Those cases are where medicine lives, and simulation so far has not cracked them. I raise this not to dismiss the Tsinghua work, which I think is genuinely groundbreaking, but to frame the question we will dig into in episode 3. Can an AI actually take a clinical history? Because the answer is more complicated than the MedQA number suggests. Now let's look at the scientific contribution of Agent Hospital. Agent Hospital is, I believe, a genuinely important scientific contribution, not because it proves AI doctors are ready to replace physicians, but because it proves that simulation-based training for AI clinical agents is real, scalable, and capable of producing measurable clinical performance. That is new. That changes what is possible in medical education, in AI development, and eventually in the deployment of clinical tools. The Tsinghua AIR group built a hospital that does not exist. They trained doctors who have never touched a real patient on 500,000 synthetic cases. And what those doctors know, as measured by a hard clinical benchmark, rivals what a human physician knows at the board exam level. That is the AlphaGo Zero moment for medicine. But there is a gap between passing the boards and taking a great history. Next week, I will show you a benchmark that exposes that gap with precision. The AI hospital paper asks a question no prior benchmark had the nerve to ask. Not, can AI answer medical questions, but can AI actually talk to a patient? The answer will change how you think about every AI in medicine claim. I'm Dr. Trevor Turner. This is the Medical Operating System. See you next time.